chairperson at Madurai Medical College, MBBS and MD from Madurai Medical College. Welcome, sir. He served as a curriculum committee member of medical colleges, currently interested in medical education skills and techniques. I would like to invite Dr. P. Ramanathan. Welcome, sir. He's a senior consultant physician in Sri Ramayya Medical Clinic, formerly served in Railway Hospital, Madurai. Over to the chairperson.
Considered as a T20 match there, the last 3 overs. I think the last session, the last 3 batsmen were actually batted very well and they made the sessions very lively. Not only informative but also emotional they made it. So I think now we have 3 local batsmen here. So there is no need to introduce them. Yes, they can introduce Jasmine to Madurai, but I cannot introduce Baraka to Madurai. So all 3 names are household names in each and every physicians, sitting physicians here. So straight away I am going to invite Dr. Anand Kumar Annamalai sir to present a session on religious fasting in diabetes, how to manage.
Good afternoon. As always, it's a great pleasure to be at Receptor, my very good friend, classmate right from school on to college, Kumaravel. It's great always to be at this podium. So the chairperson and you just told me that local pasanga irukkreenga borota solreenga fasting pathi pesukren and religious fasting. The problem is whatever fasting it's always followed by feasting, and that's something which we need to understand. Whether it is religious or whatever we call it, fasting is always followed by feasting, and that's a problem in diabetes. And we will need to know that underlying thing in terms of management of diabetes, whatever type it is. So I've got no conflicts of interest for this talk. I don't like barotas, so but so the religious fasting, it can vary depending on what kind of religion it is. So today's talk, what I've done is I've just pitched up in a practical way, give you real life clinical scenarios, and trying to kind of make it kind of you've got a patient in front of you, what you need to tell them, and also string some evidence with this. So we have fasting based on Hinduism, Islam, Christianity, Buddhism, and Jainism. And if you look at those fasts, you have different varieties. You have fasts which are periodic, you have fasts which are continuous. It could be for a day, it could be for a day or 2, it could be for a week, a month, and so on and so forth. Remember, we're not talking about your intermittent fasting, your other types of diets which are there. We're talking about religious fasting. So if you look at Hinduism, in the north, you have this Kavachal, you have the Guru Purnima, which basically is a kind of fast which is for a day, an entire day, which is more than 12 hours. So the hours duration is important because that decides on how you actually go about treating it. Then it's important to understand, what do they do? Do they really fast? Because sometimes they say nirahara, which means you take nothing. And then say phalahara, or meaning you take fruits. Sometimes they are allowed certain things, so it's not really a fast. So when someone says I'm fasting, you need to ask them to define it. What do they do? How long? So, and you cannot assume that this is a standard practice. And I think that is a very important definition which we need to address. Now, Islamic fasts, we know that it's very typical. So it's a month long. It's basically from dawn to sunset. People are going to break the fast in the evening, and they're going to break and take another meal before sunrise. Now that's known. But again, still, I would urge you to actually talk to them and actually find out what they do. Now we have Lent. You also have basically certain fasts like in Jainism, where basically they don't do anything. They don't drink, they don't eat anything. So these are things to be careful, and it's very important to understand. Now in the Tamil context, periodic fasting, and this is important because these are the patients you're going to see. They'll say, Iniki Pradosham, Iniki Ekadashi, Kanda Shashti, Iniki Veradurutno sir. So what is it? So you need to understand what is it. So if it's Ekadashi, it's actually a 36-hour fast. So this is the normal, Hinduism norm. But you need to ask them what they're going to do, because they actually fast for 36 hours from sundown, the entire day the next day, and then break the fast the next day with some agatikirai. They will take some amla and some sundakai. So this is what is the routine, practice. But you need to ask them what they do, because it may be different. Pradosham, or whether it is basically, Ammanakku, Mariammanakku, basically, you will need to say what's your fast, because then they say, I take cool. I'll break the fast by taking cool. So obviously that's rice gruel,
Or you will need to to understand what they do after the fast and during the fast. Kanda Shashti, dawn to dusk, with allowance for liquids, fruit and milk. So, and this Oru Poluthu meal. So that means you can eat once. Now you need to define when they're going to eat it. That Oru Poluthu could be in the afternoon, it could be in the evening. And that is important. And remember, if it's Kanda Shashti, generally rice is a taboo. They will not take rice, they will usually break the fast with broken grain. So all these aspects are important. So this is Tamil custom. And if you look through each month, everything has got some festival. The so-called fast could actually be a feast. Pongal festival. People have different kinds of ways they actually celebrate it. February, Mahashivaratri. March, there are different Nombus. April, Ramanavami. In terms of August, Varalakshmi Nombu. September, Vinayaka Chaturthi. October, Durga Puja, Navaratri. November, Deepavali, and December, Kartike Deepam. So you see, this is just filled. And this is our understanding. We will need to understand what they do. You tell them don't fast, they will not listen to you. So you need to be prepared. You need to know what is you're going to ask. And if you look at the dietary practices, amongst religious practices and fasts, this is a study from North India. And this is interesting because this is what our patients do, and this is why we need to understand. The frequency of eating can be very variable. It's so-called religious. It could be once a day, one meal with no snack. It could be twice a day. It could be thrice a day. So where's the fasting here? It's actually feasting. So this is important. And the types of food consumed. Don't be taken aback. They will tell you that, you speak to them. They'll have everything. Ready-made items, packet items, homemade items, everything they'll take. Whatever Swami will say, vada, murukku, mixture, bhaji, everything will go inside. Everything will go inside. So you define their fast. What do you do? And this is all, reported data. Cereals, pulses, milk, vegetables, fruits, oil, sugar. And this is followed by sweets. Because, you break the fast, you celebrate. You break it with sweets, special thalis, soft drinks, because you're feeling dehydrated. It's not water anymore. It's soft drinks. Or drinks added with extra sugar, because they're fasting. And or the so-called non-sweetened beverages. So these are important aspects to understand when people are fasting. So the fast is important in three aspects. What is the fast? What is the duration? What are they really doing? Are they restricting food really? Are they restricting fluids? And what's the frequency? This is a very important question. Next question is, what are they taking in types of medicine? And when you say medicine, again, lifestyle and diet. Are they really following the lifestyle and diet which we asked them to do, and it is going to be even more worse during this fasting and feasting period? If they are taking drugs, what is the hypoglycemic potential? What is the potential on dehydration? What is the potential on the GI? These are important. And who is sitting in front of you? Is it type 1, type 2? Is it an elderly person? Are they frail? Because there are a lot of our elderly people, they like to fast. We tell them don't fast. They'll say, illappa, Kanda Shashti ennal irukka mudiyadhu. Kanda coaching varum. So, you need to work with that. And also the literacy and ability to self-monitor. All these are very important. So the important aspect is first stratification. Now this is what we would like. You stratify, you tell them that they're high risk, they probably will not listen to you. So you need to be ready for it. So you tell them it's risky. You tell the relative or whoever comes with them they're risky, but still you will need a backup plan. So you classify them as very high risk, moderate risk, and low risk, based on lots of factors. If someone's had severe hypo or hyperglycemia, recent admission with DKA or HHMKC, they clearly are not candidates. Recurrent hypoglycemia and awareness, type 1 diabetes. Ideal world, yes, you should not ask them to actually fast because it will be very risky. So people who are planning a pregnancy, people who have an active illness, complications, both micro and macrovascular complications, that's a huge gamut. You practically are including a huge load of people who cannot fast. So people with renal insufficiency, living alone, elderly, frail people, all come under the high risk category. So when you say moderate and low risk, these people have somewhere, a low risk person is HbA1c of less than 7 or 7.5, treated with oral drugs or diet alone. And moderate risk is somewhere around 7.5 less, with maybe small doses of insulin, plus or minus sulfonylureas and other oral agents. So why do you classify that? Because this is important in this day and age. A1C less than 7.5, they're low risk. That means fasting is probably safe. We cannot still tell them it's safe. HbA1c 7.5 to 9, moderate risk. The fasting safety is uncertain. HbA1c greater than 9, high risk, fasting is probably unsafe. We still say probably because we do not know entirely because the long-term studies looking at it. So the risk stratification has to happen 6 to 8 weeks prior to the fast. So you risk stratify, this is in the ideal world, and then you tell them where they stand. Why? Because if they are at high risk, that means they will need to monitor, they will need to check. And that is the discipline, as Swami was saying. If that discipline doesn't exist, then it's going to be a problem. They would have to land up in trouble, or they would have to stop the fast. So if it is high risk, you will need to monitor your blood glucose at least 3 to 4 times a day. And if it is basically low risk, probably 1 to 2 times a day. So this is important. The other always important aspect, which is very important to tell patients, is when to stop fasting. And the important aspect is you tell someone with them, because they will not listen to you. You have a lot of elderly ladies, ladies who follow Islam, who come and tell you that no, whatever come, I will continue the fast. So it is very important you tell, the next of kin. If the blood glucose is less than 70, stop. Greater than 300, stop. Symptoms of hypoglycemia, so you do not wait, that means they are getting symptoms, it's falling rapidly. They are at risk for problems. Acute illness of any kind during the fast, or development of any complications relating to diabetes. This is something we need to keep stressing again and again. And this is like, the 5 commandments in terms of fasting. When to stop. The problems, as we all know, it's going to be the acute metabolic complications, the hypo and the hyperglycemia. We know that people can be variable with their insulin intake. They can be very poor in terms of monitoring. They are very erratic in their eating patterns and also in their post-feasting patterns. Now, all these need to be taken into account. So with this, we will always stress on lifestyle. We will ask them to attend this pre-fast counseling session. We will ask them to adhere to diet. We will ask them to monitor the blood glucose. We will tell them about breaking the fast, and then we talk about medications. So medications come at the end. It's important to actually tell them where and what and how to kind of approach this and when to stop this, and then talk about medications in terms of what to do. So we also need to educate people about symptoms. And why I put this slide up is there's a lot of overlap. So whether it's hypoglycemia or hyperglycemia, you can have a lot of overlap. Dehydration and diabetic ketoacidosis, you can have overlap. The dryness of mouth, can be variable. Dark skin, dryness in terms of just feeling very tired, can be very variable. So this is again to stress the need for the SMBG. And this is just the CGM patterns in Ramadan, or in normal individuals, and in terms of Ramadan with people with diabetes. As you can see, basically the fluctuation. You see the surges, and the surges are the problem because that lands up in complications. In someone who's poorly controlled, that could result in macro and also, acceleration of microvascular complications. When you look at evidence to look at diabetes therapies used during fasting, predominantly most of the data are from basically Ramadan. And it is shown that majority of people are actually on oral anti-diabetes drugs, and some are on injectables. So that means across the world, many people try to convert to oral anti-diabetes drugs with an addition of maybe, once or twice daily insulin or injectables. So with this background, I'm going to give you some real life cases. So this is Mrs. Sudha, who's a bank manager. She's 32 years. She's had diabetes for a very long duration. Her fasting is 184, postprandial is 236, his A1C is around 10. She comes for her visit and she says, I want to regularly have this fasting for pradosha. Now, as I said, pradosha happens at certain frequencies every month. That would mean that she wants to do this regularly. So that's her custom. I think we need to respect it. But we also need to give her information as to whether it is safe. So going with this, the question is, what is she on? So these are her medications. She's on glimepiride, 2 milligrams twice daily. She's on metformin, she's on sitagliptin, and she's on biphasic insulin Ryzodel. So the question here is, can she fast for pradosha? This is the first visit question. The question is, the answer is, she actually is unsafe, even if it is like, a periodic fasting once a week or, once in 15 days. She actually is at very high risk in relation to what she's taking. So with this, the pre-fast counseling, will result in actual changes. So we actually changed her insulin gene to Lyspromix, 12 and 8. And this sometimes is an opportunity to tell people to change their way they eat. Because they say, look, if you want something, you need to pull up your socks, you need to have the discipline, you need to have the attitude towards control. So with this, they have something in front of them saying, okay, I would want to fast. So second visit, she comes back, the A1C's dropped down. From around 10, it's come down to 7.4. Now she puts the same question again. This is after 3 months. Can I fast for pradosha? So remember now she's on Lyspromix twice daily. She's on metformin, glimepiride, sitagliptin, and telmisartan. Now she's in the low category and she's safe for fasting. But how do you go about this? So again, the same questions. Again, tell her when to stop fasting, when not to actually, when to stop and when not to actually go ahead with the fasting. So with her, she's taking glimepiride. So sulfonylureas, she needs to stop the glimepiride on day of fast. Remember, pradosha is more than 12 hours. So the sulfonylurea on that day has to be stopped. The metformin she's on twice daily, she can continue. The DPP-4 inhibitor, sitagliptin, she can continue. She's on taking Lyspromix twice daily. She can stop the Lyspromix 50 on the day of the fast in the morning, and she can use 2/3 of the dose for the night meal. And then the next day, she can revert back to normal schedule on regular days and follow the above schedule for the fasting days. And that means that actually she gets in control and she's empowered about her diabetes. That means she's going to monitor. And this sometimes can be, an incentive to tell people, how to actually, control things. This is Mrs. Ashraf. She's 46 years and she has diabetes again for the past 8 years. She wants to fast for Ramadan. Her HbA1c is 7.4 and very much under control with oral hypoglycemic agents. She's on glipizide, 10 milligrams twice daily. She's on metformin twice daily. She's on empagliflozin 25 once daily. She's on antihypertensives and is on a statin. So can she fast for Ramadan? Now again here, she is low risk and she's safe to fast. Now, how do you go about this? Again, now even though she's on oral drugs, you will need to tell her when to stop fasting. I think this is very vital, as always. What do we do with her? Now she's on glipizide. Now glipizide is not an ideal drug for fasting. So you would need to change to the modern fourth generation, sulfonylurea. There's a lot of data with glipizide, modified release. There's a lot of data with glimepiride. So you would need to titrate few weeks prior to Ramadan. And this can be based on self-monitoring of blood glucose. And during the fast, she can take gliclazide or glimepiride during her normal morning dose with her evening meal. That's when she breaks the fast. And during the fast, and normally in the morning, she can either omit the sulfonylurea or take half of her dose. And this again would need to be monitored, especially based on SMBG. Again, you will not find a lot of RCTs to support these evidences. You would find RCTs to tell you what to use and how to go about it. As far as metformin, you continue 500 milligrams twice daily. Empagliflozin, yes, it can be dehydrating, but you can actually continue it. You can continue it at night. You need to tell them to drink a lot. You're high risk, you're unsafe. Okay, you stop your gliclazide, but I'm actually going to give you something else. So she said, I'm very adamant, I want to fast. Fine, I said, you would need to prove that basically you get your glycemia under control. So we continued the empagliflozin. We actually started vildagliptin. We continued, increased the metformin to 500 twice daily and actually started her on a basal plus insulin regime. And with SMBG. Again, this is an opportunity to tell them, how you could actually do things. She comes back 6 weeks later. She insisted for her HbA1c, and we did her HbA1c, it dropped to 8.2. She wants to fast. Now, is she safe? Now, these are the main agents she's on. She's on insulin, she's on EMPA, she's on Vilda and metformin. Now, this is moderate risk, it's uncertain safety for fasting. Now, she says, am I safe? You really can't tell me you're safe. It's uncertain. You've not taken care of yourself. So, again, when to stop. That's important. You tell them. What do? SMBG at least 4 times daily. Decrease metformin 500 twice daily. Continue the empagliflozin, continue the vildagliptin. And there are a lot of ways you can do this. I continued aspart mix at night at the same dose, and I halved the usual lunchtime, short-acting dose in the morning, and titrated it. And I encouraged her to use the CGMS and give us values and based on titration with that. So just quickly, for 1 minute, SUs, as we just mentioned, the modern generation SUs are much better. This is level 3 and grade C recommendation. The short-acting insulin secretagogues like repaglinide, sometimes for short, immediate burst, it's pretty useful. GLP-1 receptor agonists, generally no dose modifications. However, the vomiting and nausea, you need to be careful. DPP-4 and SGLT2s, no dose modification, but you need to increase an extra fluid. Metformin, you could continue. Acarbose and thiazolidines, you could continue. As far as long and short-acting insulins, generally, you would need to reduce your long-acting insulin by 15 to 30%, and you take it with the evening meal for Ramadan. For the short-acting insulins, generally you avoid the afternoon dose, and it's based on SMPG again. As far as type 1s, you could reduce your basal insulin by 20 to 30%, and the short-acting has to be with SMPG. Without SMPG, it's not possible. Type 1 is generally not ideal to actually be fasting. So I'll probably just stop quickly there with a few practice points. As I said, fasting, yes, but remember they're going to be feasting. So don't get fooled by them if they say they're fasting. Religious fasting has to be discussed and risk assessment has to be carried out, and it's important to plan as per the fast and tell them when to stop. Diet, lifestyle has to be stressed, regular SMBG, and informing the family about what they will need to do in case of emergencies. So thank you very much. I'll probably stop there.
A very nice session. Fasting, it's a very interesting topic. Sir has mentioned fasting, whether it's a real fasting that is followed by a feasting, we should also think. Hindus fasting, there are three types. Palahara fasting, Palpana fasting, and Patni fasting. So, sir, brother Kapuran get a sir, who never eatly sabron, fasting. Palpana fasting. So, we should have to decide what should be. So, questions will be taken at the end of the session. I request